Okay. Well, since everyone else is muted, I guess I don't know if everyone else can hear me. Can you guys,
Yes.
hey, host Beef.
I can hear you.
I hear you.
All right. Well, all right. Awesome. I hope everyone is here. I'll have some kind of record on this. Yeah, I do have a record for this. All right, guys. I hope everyone is doing well enough at home. Today we start abdomen and superficial structures. As I stated in my email, I started with the PowerPoint I did a recording of it, and just to see what it would look like if I posted it, how it sounded, and it was painful. It was, I mean, PowerPoints are always a little difficult, but this one was online or talking to no one at the time was extremely painful. So I've decided on a different format. I hope this works out. I think it will. We are an imaging modality, so we have definitely some images. What you see before you is basically day one. At least it was planned on being day one. We might go through this a little faster than I had planned, in which case we would go to my planned day two, which would be still within chapter 2 of Kawamura, Abdomen and Superficial Structures book. Oh, you know, and one thing I should I cannot pull something off to the front. Okay. Well, I was going to pull, I have a second screen here. I was going to pull up the syllabus for this semester, at least in this class. Suffice it to say, the syllabi are posted for all technically 4 classes, 2 classes, 2 labs. And in the 2 main classes, a schedule has been posted as well. Now, that schedule is not going to be adhered to extremely well this semester. Depending on how long we're doing this, it looks like we're probably going to try to get a little ahead of schedule in the classwork, because when we finally go back in, we're going to have to do some catch up on the lab. I'm not really concerned about catching up on lab. I think we're going to do just fine with that. But well, let's go ahead and get started. I can't think of any other housekeeping stuff. I set this up for every day at 1 o'clock. I'm going to remove the waiting room feature, and I think that'll put you directly into the meeting. You might not have a screen to look at if I haven't yet opened up my computer and shared my screen. So just going forward, a slight little change on that. But let me start up in the corner. We're just going to be working around. We're going to be looking at regions of the body, and we're going to start looking at the abdominal wall, posterior abdominal wall, inguinal canal, also diaphragm, some disease states, abscesses, hematomas, and some representative images as well. This was a nightmare to put together, but fortunately, I seem to have it set up a little better. Okay. Okay, so the anatomists, doctors, whomever, they separate the abdominal and pelvic cavities into 9 regions. The first being the epigastric region, which is really in here in the middle of the, right below the xiphoid process. And as many of you know, that is where we start our ultrasound exams. Let me get a little bit of a different color here. And in fact, when we start our exam, we typically start with our transducer right about there. Let's change something here. Okay. And that's the typical placement to start our exam. There's a couple reasons for this. One, obviously, there's a liver behind here. That's one of the main organs we're going to be looking at. Behind that liver, there's an aorta, there's an IVC, there's other mesenteric vessels to look at. There's a pancreas, which we're seeing just a tiny little bit of the head behind the stomach. But the other reason to start it here is the liver normally is a good window. When you look at other locations in the abdomen, it's a very poor window, and we don't see anything at all. So generally, most people start on a sagittal picture of the liver right here, and the epigastrium. You know, depending on what they're starting with, if they're starting with the liver, they're going to sweep way over to look at the very tip of the liver. That's something that I am adamant about. I want to see you're sweeping all the way over. And that doesn't mean you have to slide the transducer. In fact, once you hit these ribs, your image is going to go down in quality very quickly because we cannot see through the ribs. So it's just a sweep over to this side, all the way to the left, all the way to the right. The next place we would look would be, well, same spot, but transverse imaging. With transverse imaging, I am adamant that you look all the way up until you see the heart, which is up here, and then you look all the way down past the liver. Tumors, abscesses, other things are not always in the middle of the organ you're looking at. Sometimes they're off to the side. So we do want to look for that. So that's our first region, the epigastric or epigastrium. The second, whoops, I am in the wrong setting here. The second, the hypochondriac, the right hypochondriac, as we're going counterclockwise here. I don't know the connection between the name of that and someone who thinks they're sick all the time. I'm sure there is a reason for that, but that's the right hypochondriac or hypochondrium in this area. As we come further down, we have the right lumbar, also sometimes known as simply right lateral, which I think your book prefers. I've even said, you know, in my time scanning, I would also call it the right flank, and everyone knew what I was talking about. But right lumbar or right lateral are both good for that. As we come further around here, there's a small area, and this is the right inguinal. Inguinal area, you may find an appendix in that inguinal area. And the inguinal, although is rather important, especially for men, which we'll talk about very soon. However, with men, it's a little more medial back into the hypogastric or suprapubic area, and that's this area as well. And of course, we go to the other side. We have a left inguinal, left lumbar, left hypochondriac, and if we were to place a belly button right here on this person, the area around that would be, let's see.
I'm sorry.
Priscilla
says that she's trying to get in.
Oh, okay.
You have to let her in.
Oh, yeah. I'm gonna delete. Admit all. Sorry about that. Yeah, I'm. Next time we go forward, I am not going to have a waiting room. That was a mistake on my part. That way, we won't we won't be leaving anyone behind. But you haven't missed much. We were just talking about the.
Here.
We're just talking
Sorry, can
about
you hear me?
I could hear you.
Okay.
you might want to mute.
Sorry. Okay.
All right. So we were just talking about the epigastric area, the hypochondriac area, lumbar area, inguinal area, and hypogastric or pubic area. And look at that, I got 3 in a row. Lucky me. And then, of course, left inguinal, left lumbar, and left hypochondriac. This next image over here is really just the same thing. I just figured I'd pull 2 pictures of this. Epigastric, hypochondriac, lumbar, iliac, hypogastric. Yeah, this picture pretty much uses the same terminology as the first. Now, the good thing is, guys, is that although I do want you to learn these terms, in the real world, we keep it simple. We keep it right upper quadrant, right lower quadrant, left upper quadrant, and then left lower quadrant. And in fact, one of our common exams is simply the right upper quadrant. And typically that means what they're really looking for is what's going on with the gallbladder, what's going on specifically with the liver. So if they order a right upper quadrant, that's really what they're looking for. If they order a full abdomen ultrasound, then we're looking at the liver, the gallbladder, the kidneys, all the vessels, spleen over on this side here. But in reality, we use a more simple terminology of the 4 quadrants. Okay. So those are our quadrants and regions. Let's talk about the, sorry, I just got tangled. My cord. Okay. Let's talk about the rectus sheath. Now, when we talk about that, we are talking about the anterior abdomen, the stomach muscles. So the rectus abdominis, that's your 6-pack, if you have a 6-pack. What's shown here is 1/2 of the side 6-pack, and of course, this is a transverse picture. So we're seeing the rectus abdominis in transverse. And the reason it's created by using a bunch of small circles is that would indicate the cross section of each little bundle of muscle fibers inside of the entire muscle. Now, the rectus sheath is a aponeurosis. Well, an aponeurosis. I wrote it down here earlier because I want to make sure, very important that I get to it. An aponeurosis is like a tendon. It's very similar to a tendon. It's very strong. But unlike tendons, it does not connect muscle to bone. It connects, well, sometimes muscle to muscle, usually muscle to muscle. And so, and since our belly, let's move this over a bit.
Sorry, Mr. S, can you
Yep.
accept it? I got my computer to work. Can you accept it? Can you let me in so that I can use my computer rather than my phone? It's your like really small screen. Sorry. Thank you.
Sorry. Well, glad to see you're here. So the aponeurosis, once again, not quite shown in this picture, actually. I have another picture that's better for the aponeurosis, but it is simply very similar to a tendon. except rather than muscle to bone. Whenever I get confused whether it's a tendon or a ligament, which does which, I always think of the Achilles tendon connects my calf to my ankle. So that reminds me that tendons do muscles to bone, ligaments. If you think about the knee, and like you could have a anterior cruciate ligament injury, that is bone to bone. But an aponeurosis is usually muscle, and as we go all the way across, it'll attach to the muscle as well. Now, there's two pictures here of the rectus sheath. One shows that the rectus sheath goes over and under. I am recording. Okay, over and under the muscle. But it also shows this picture where it goes simply over the muscle. Now, I don't know why we even mention this. This difference is very, very difficult for us to see on ultrasound. These are not exactly brilliantly colored or brilliantly shown on ultrasound. But the difference is the arcuate line. And the arcuate line is actually a little bit different for everyone. We don't have, we can't say that it's exactly the same place for everybody. But at some point below the umbilicus, the umbilical, or the belly button, the arcuate line is where the posterior rectus sheath just simply stops, and instead we only have transversalis fascia. Now, hey, actually, I could handle that. Hold on. We got.
Thank you.
Mute. Mute all. There it is. Current. Let's see, but I'm not muted though. No, it doesn't look like it. Okay. So at the arcuate line, like I said, I don't really know why they're even making a big deal of this. This would be very difficult for us to see. At the arcuate line, the posterior rectus sheath ends, and the only fascia and is the transversalis fascia. Now, the difference between fascia and aponeurosis, like we said before, connects muscle to something else other than bone. Fascia is also, it's a connective tissue. We have layers of fascia within the body. There's subcutaneous fascia that tends to be a little more weak, but also high in nerve and blood supply. Then we have a deeper fascia that is deeper in the skin level and then also goes down, covers and surrounds the muscle. So every muscle is surrounded in fascia as well. Fascia, your book kind of didn't mention this on the transversalis fascia. So that is fascia that is lining the inside of the abdominal cavity, abdominal, pelvic, and for that matter, chest cavity or pleural cavity. There is a fascia. It's not all called transversalis fascia, but it is all continuous as one big fascia envelope around the inside of our body. Now, one thing this picture is not showing is there is another level that we're going to talk about later, another level down here, and that would be the peritoneum. So that's why the abdomen is sometimes called the peritoneal cavity. Oh, actually, I'm sorry, it is mentioned right here. So they're calling this level the peritoneum, and the level right above it is the transversalis fascia. Okay. So I really like this picture. It shows everything going on in pretty good relief. once again, we'll start from the top here. There's that peritoneal cavity as well. And that peritoneum, that is following along in here. That is one continuous loop of connective tissue inside of the body. It surrounds the abdomen as well, just like the fascia surrounds the abdomen, but it also surrounds most of the organs of the abdomen are within the peritoneum, but not just within it, but actually covered in it as well. Of course, we're going to be talking about that, I think, Wednesday. The muscle. I did want to mention the muscles a little more. I could do it right here, though, and I'll go back to the other picture. We do have 3 muscles that help us turn, twist. That is the external oblique. That is this muscle right here. Whoop. Internal oblique. That muscle right here. And the transverse abdominis, which is the innermost muscle here. Let's move back just a little bit. Let's move all the way back to here. I forgot to mention it right here once again. These 3 muscles, the external oblique, internal oblique, and transverse abdominis, 1, 2, and 3, they form the fascia that surrounds those, comes out, and they form the aponeurosis that goes across and creates the the rectus sheath. And we do have more imaging on that as well. Okay. Obviously, this is a kidney. That kidney is actually surrounded in renal fascia. All kidneys have a decent amount of fat around them. It is supposed to be there. It protects the kidneys. The psoas major muscle is a pretty important muscle for us as sonographers because we see it all the time. And if you see it in transverse and someone does a lot of sit-ups, this muscle will be quite large. In fact, when I was working for a military hospital, I had a female soldier in, and she was being, I wish Michael was here, I can't think of the term, removed from, she had a discharge from the, an honorable discharge from the military because she did too many sit-ups. Just a little hint, if you do a sit-up and you hear a popping sound in your hip, change your position. If you continue to hear a popping sound, don't ever do sit-ups again. They're not the best thing for you in the world necessarily. But if you're going to do a sit-up, this is one of the major muscles helping you do that sit-up. If you're only going to do stomach crunches, well, then we're doing rectus abdominis muscle. But in any case, the reason I mentioned that girl in the military is that she had done so many that I thought she had an abdominal tumor until I turned sagittal on it and realized that, yes, I could see that it was clearly a muscle. She just had a huge muscle. And I talked to her about it. She says, yeah, in fact, and she told me the story of why she's getting discharged from the military. So the psoas major is important for us because we see it. We see it in the abdomen, and we can see it all the way down in the pelvis as well. Coming down, the anterior layer of, and I don't even know what TLF stands for in this picture. I know that F is for fascia. And posterior layer of the TLF, or whatever that is, fascia, is also called endo-abdominal fascia. But remember, this fascia is continuous with all the fascia. It is continuous with the transversalis fascia as well. So it is all basically one piece. The other muscles, latissimus dorsi, you're probably not going to see in the abdomen, although possibly as you're looking down on a kidney, you might actually see a latissimus dorsi. Quadratus lumborum is another muscle that is not typically well appreciated with ultrasound, but we can see it once again, especially when we're looking through the kidney. If we're looking through the kidney from way off on the side here and looking this way, the muscle you're going to see is the psoas major, the psoas muscle. And of course, if you're somehow looking, whoops, I can't draw downward. If you're looking down, you might see, I don't know how this is my daughter's drawing pad. I don't know how she does it so well. I guess if the pad's sideways, I'm going to draw sideways. That makes sense. Well, in any case, if you're looking down, you're more likely to see the quadratus lumborum or maybe even the latissimus dorsi muscle. And the erector spinae muscles, probably not worth getting too much into because we probably won't see them. Although, once again, it's possible to see behind the kidney. Okay. The heck just happened here? Okay. Okay. That was, of course, a sagittal, I'm sorry, a transverse image. Now we have a nice image of the posterior wall of the abdomen. The muscles, these muscles coming all the way, well, let's just start with this one. We're going to talk about the diaphragm later, but this is all the diaphragm. This is all the diaphragm over here. And the psoas major and psoas minor, you could see that there's actually two muscles here. Both come from, they attach to the spine, but they actually come from above the attachment of the diaphragm. The muscle over here, not well seen here, not well read here, is the iliacus. Oh, writing's even more difficult with this. I have to get used to that. The iliacus muscle, that attaches to your hip bone. It goes through and actually comes all the way down, attaches to the femur, along with the psoas muscle. And in fact, once it gets down to about this level, it's no longer called the psoas muscle and iliacus muscle. It's the iliopsoas muscle. They become one muscle down at that level. I think that's all we need there. Okay, now here's a nicer picture of that aponeurosis. The linea alba, the white line, runs down the middle, and you can see this person's got a nice six-pack going. The linea alba runs down the middle until it gets to the umbilicus, the belly button there, and then continues on. The aponeurosis is the fascia, the muscle fascia. You could see the external oblique coming down in this direction. This is also a good picture to point out our inguinal ligament. The inguinal ligament kind of separates the pelvis from the leg. Once you cross over that ligament, and it's something that you really can't see per se on ultrasound, you kind of know where it is. It's basically at the crease of the leg. If you were to bend your leg up, you pull your knee up, it's where the leg bends. That's where you're going to find the inguinal ligament. Once again, important location, especially for men, because of right here. It's basically a defect in the aponeurosis of the external obliques here. So that's what I was going to say. The inguinal ligament is really an extension. It's almost like a rounded fold of this aponeurosis. So it really is kind of all goes together. But this is a weak spot. And it's a weak spot in both men and women, but it's worse for men because men start off life with their testicles in the pelvis. And it's not until right before birth that they migrate out. Because of that migration, it leaves this inguinal canal weaker in men. And then also we get stupid and we lift things that we shouldn't be lifting. And when we lift hard, we create a tremendous amount of internal pressure inside the abdomen because of the flexing of the rectus abdominis and the external and internal and transverse and external obliques, internal obliques, transverse muscles, transverse abdominis muscles. When all of those flex, you create a tremendous amount of pressure and a little bit of either fat or sometimes even intestines could actually squeeze out through this canal. Another location, by the way, another weakness is the umbilicus itself. Of course, we all have that weakness, and it is because, that's because that's where your umbilical cord went through the abdomen. So that is it's a defect in the aponeurosis, really. All layers of the aponeurosis do fuse around here, but in the middle, it is actually a defect. And so I do have an image of a small umbilical hernia we could see later. Okay, let's move it all. Moving right along. Let's bring both of these up. Hopefully you could see both of them at the same time. I've got a really wide screen here. Okay, so this is a great picture. Oh, there's one other muscle. I just saw this right here. And that's actually a silly little muscle to even include. Some people don't even have this muscle. And I'm suddenly forgetting the name of it. It's a triangular, triangularis. All right, I've completely forgotten. I know it's triangle something. It's a tiny little muscle. In fact, some people don't even have it. It is pretty much a worthless muscle. The only thing it's attached to is actually the linea alba. So if you want to flex your alba, I guess you have to learn how to flex that muscle. But the muscle behind it here, this one here, is rectus abdominis, the most inferior rectus abdominis muscle. You could see layers of fascia. You can also see where there's a bit of a problem here. This is the inguinal canal coming through. So in all these areas, that is a weakness. Once again, external obliques, internal transverse abdominis muscles, and their respective fascia planes coming around. Okay. Let's just pull it over a bit in case you guys can't see what I'm looking at. Basically the same picture. I don't know if there's anything else I could say with this. No, I don't think there is actually. Let's keep moving. And of course, I forgot to set my timer. It's one of the That's okay. We've got a few more minutes. I think we'll take a break in a little bit here in about 10, 15 minutes. And then I want to have just a little discussion to see how this is going for you guys, if you have any kind of technical issues or if this is boring the heck out of you. If it's boring the heck out of you, that's kind of too bad, but I still want to know because I'll at least try to do something about it. We do talk about hernias later on, but I figured I would just show quickly, since we're talking about the inguinal canal over here, show quickly the anatomy of a inguinal hernia. So normally intestines are held within the peritoneal cavity, but with a indirect hernia, the either fat or intestines can actually extend. And what they're really showing here, I actually don't like this. They're showing, as I'm drawing this line here, kind of continuation of the peritoneal cavity. And that's actually not true. It's more of a tear right through the side of the cavity. So, and what happens is fat or intestines could actually go all the way down into the scrotal sac. In direct hernia is similar, although in this case, what's happened is that there was a side blowout. So this will not go all the way down into the scrotal sac, but instead, and it's still quite painful, and I will train you how to look for these. But this is kind of more of a sideways blowout at the inguinal canal. So let me just quickly look at my notes. I haven't looked at them at all yet. Make sure that I've defect. Oh, I think I've only seen one thing that I failed to mention. In the female, let's pull this backwards here just so we could see. In the female, well, in the male, this is the spermatic cord. It would have obviously arteries, veins, vas deferens for the most part, and nerves. Trust me, there's nerves. But for the male, that is a spermatic cord. For the female, it's actually the round ligament of the uterus. And so, and it's very odd that the round ligament comes through the inguinal canal, attaches to the pubis bone, and comes all the way back and through and attaches to the top of the uterus, the fundus of the uterus. Okay. So moving right along. All right. So what I want to talk about here then, this is, all right, so in case you don't recognize it, we have our lungs here. The heart would be right here. And you have this diaphragm. Now this is a very stylized picture of the diaphragm, but basically, the rib cage all the way up to the xiphoid process, all the way back, back down. Can't draw a straight line. It's attached to the edge of the rib cage. It's attached to the back of the rib cage. It is a dome. It is a double dome, which is not shown in this. In fact, this image is way too, way too symmetrical. Both lungs look identical. Well, they don't. Actually, there's 3 lobes on this lung over here and 2 lobes on this lung. This is not quite so symmetrical either, because we have a liver over on this side, which lifts this side of the dome of the liver, dome of the diaphragm a little bit higher. But I picked it because it really shows these 2 guys. And what these are called the crusts of the diaphragm. And these are muscular attachments. They are attaching to the spine. Their spine's coming down here. And these are attaching to the spine. And the curvature up here is the aortic hiatus. That's where the aorta is going to have to come through. The only reason I mention this is because these are important. Okay, they're not terribly important for us to know, but I like for my students to know this because I want them to recognize what they're looking at when they see it on an ultrasound. That's a crus. Oy. All right, that's an R. Okay, so that's a stylized picture. And let's bring up a little better image for us to look at. This one does show the diaphragm and its muscle attachments. Muscle attachments are down on the rib cage and along the costal line and all the way up on the xiphoid, and those little xiphoid process here, and back down again. And then if we could see more behind, it's going behind as well. So it's attached to your back as well. By the way, when you get punched right here, takes the wind right out of you. The reason for that is because you have activated a nerve that tenses and almost paralyzes the entire muscle for a short amount of time. And so first it tenses, blows all the air out of your lungs, and then you can't take another breath in for a little while. Notice that the dome is higher on this side. This is a little more accurate image. And that's because the liver is sitting over here, mostly over here, so the left lobe goes across here. And it shows kind of a nice picture of the crusts again, C-R-U-S, the right and left crust. The right crust is a little larger and actually typically a little bit longer. Aorta is coming through right there. All right, let's move it. Moving right along. Okay. Now, there's those are two pictures. Of course, we're looking straight on. This is I would say a transverse picture, and it is looking upward. So if you could look, if you could put your head inside an abdomen and look upwards, this is what you'll see. This caught my eye right off the bat. The central tendon is a aponeurosis once again. Muscle, aponeurosis to muscle. The inferior vena cava, notice that it enters the pleural cavity or the chest cavity much higher. Well, much. I mean, we're talking about centimeters inside the real body, but higher than the aorta, which aorta comes down. The aorta, of course, the aorta comes out of the heart, goes up and around, goes behind the heart, and then down. The reason the IVC has to come in at this level is because it has to come in and enter pretty much immediately after going through the diaphragm. It enters the right atrium of the heart, and so it has to be higher up. The esophagus enters anterior to the aorta. So when we're up here with our transducer and we're looking straight down, we may see the esophagus. Well, and here's a little trick that I'll show you in lab, certainly. We see the esophagus, then the crus, then the aorta. The crus seen on ultrasound is just a thin hypoechoic line, but it's simply good to know what it is. Once again, we could see our muscles psoas muscle, quadratus lumborum muscle, actually attaching. It attaches all along the spine, but it also, even all the way up beyond the diaphragm, it is attaching. One 11:45. I tell you what, guys, I am going to make you see if, because there's really there's not a whole lot left as far as, well, let's see. No, we have to talk about the abscesses, well, abscess versus endometriosis on that one, hematomas. So I guess there's probably 20 minutes left of this presentation. That's not to say I don't have another one for you, but we'll figure out what we're going to be doing because this is new for all of us. So why don't we all take a break?